should know how to ventilate properly. So my main objective for next 1 hour would be to go through the basic modes of ventilation. Just I'll share the screen one. Is my screen visible now? Yeah. So is my screen visible now?
Yes, sir, it's visible.
Yes. So we'll talk about basic concepts, how different modes work, and try to keep it as simple as possible. We'll go through basic pressure and volume ventilation and focus more on volume ventilation also in this talk. And I have been asked to discuss about few common disease-specific ventilation strategies. We'll discuss in the last few minutes if time permits. So the basic goals of mechanical ventilation in any age, particularly newborn, is to ensure that adequate pulmonary exchange is being done. That means hypoxemia is prevented and adequate CO2 washout is being done. So both O2 and CO2 are being taken care of. At the same time, to ensure that baby is having comfortable breathing and there is no walk-up breathing. The whole key of medicine is to do no harm. Whatever you're doing, at least do no harm. The same applies to mechanical ventilation also. If you're ventilating, always ensure that we are not injuring the lung. So don't be overzealous and try to minimize the lung injury. So there are two basic concepts of ventilation. So there is something called firefighter approach, which I would say is not used nowadays. So people wait for things to happen and they use very overzealous pressures, oxygen, tidal volume to ensure that things happen very fast and there's no time for patience, and usually things are destroyed in the long run. The other approach is the gardener approach, which is a more milder approach, which anticipates things, which ensures that there is no harm to the baby, and it's a more nurturing environment. So this is what we should approach, the gardener approach. We should be careful, watchful, and we should ensure that we are not doing any harm to the baby by ventilating. This thing has already been discussed. I hope Dr. Ankit has discussed in the last class, but I'll just start off with this basic variables, which is needed for the next 1 hour. So the basic is something called trigger. So trigger is something which initiates breathing. So we'll discuss about different modes of trigger and its impact in the next few slides. So trigger is the variable which initiates breathing. So it may be pressure, flow, and some few things which we'll discuss later on. Limit is which causes the gas flow regulation during inspiration. So the variable which regulates the gas flow during inspiration is the limit. Cycling is the variable which decides when the inspiration ends and when the expiration starts. So cycling from inspiration to expiration is cycling. So trigger, limit, and cycling. These three variables are very important to understand the basic concepts of various modes of ventilation. Breath, if you talk of breath which is being given or which is seen during mechanical ventilation, there's something called spontaneous breath, which a baby is normally breathing. There's something called mandatory breath, which the machine controls and delivers irrespective of baby's spontaneous breathing. Assisted or supported breath, which machine supports baby's breath. So there are three basic breaths which we should all know: spontaneous breath, mandatory breath, and assisted or supported breath. So we'll discuss how mechanical ventilation is divided by type of control and type of breathing initiation. So basic is by pressure or by volume. There's something called hybrid mode or volume guarantee mode, which we'll discuss in the later part of my presentation. So the basic ventilation, which is normally worldwide used and has been used for last few decades, is a TCPL. So something called time cycled pressure limited. We already discussed what is cycling and what is limit. So pressure limit with time cycling. This has been used in neonates for almost 5 decades now. So PIP is predetermined here. MAP is dependent on the PIP, PEEP, TI, and flow. I'll not go into details of this because basics of ventilation has already been covered. But in TCPL, the tidal volume is variable that is determined by the compliance of the baby. So pressure is predetermined. Tidal volume is variable in TCPL. So advantages of this is, just give me a minute. Yeah. So advantages of this is the whole inspiration PIP is delivered throughout the inspiration time. That is a good point of TCPL. And the flow curve is sinusoidal, which we'll see in the next few slides. Disadvantages of this is the tidal volume is variable. You cannot control the tidal volume. In fact, evidence shows that tidal volume is the culprit everywhere. So tidal volume should be controlled and should be measured. As tidal volume is variable, there is high risk of volute trauma. And volute trauma is more risky than barotrauma, which we'll discuss when we discuss volume ventilation. Coming to the other mode, which is time cycled, but volume limited. So cycling is through time, fixed time cycle is there, but the limit is volume, where tidal volume is predetermined by the clinician. And here minute ventilation is more important, where it is dependent on the tidal volume and the rate you set, or rate which baby is breathing. MAP and PIP is variable. Here the tidal volume is fixed, but MAP and PIP is variable. Advantages for volume ventilation, volume limit is the constant tidal volume is being delivered, and there's auto-weaning of pressure. We'll see in later slides. Disadvantages is flow curve is square wave, which with increased PIP is required to deliver certain volume. So let's see this waveform. This is the pressure time waveform. In pressure limited ventilation, there is a square waveform of the pressure waveform, but the flow waveform is sinusoidal, which is good for the baby. So PIP is delivered instantly and is delivered throughout the I time, which is a good point about pressure ventilation. But in volume ventilation, there is a square waveform with high pressure being delivered, but not throughout the I time, but only during end of the ventilation, certain part of the ventilation. So there are advantages of pressure time waveform, pressure limited ventilation, and some advantages of volume limited ventilation. So this is the basic of types of controlled by the machine. If you talk of type of breathing, there are two basic concepts: non-synchronized and synchronized. So in non-synchronized, there's something called intermittent mandatory ventilation, where the frequency of the rate of breathing is fixed by the machine and the I time is fixed. If you talk of synchronized ventilation, there are different modes, where SIMV is the standard mode of synchronized ventilation. The better version of that is assist controlled or SIPPV mode, where in SIMV, rate is fixed, TI is fixed as in IMV, but there are some variations of that. We'll discuss each and every ventilation mode in detail again in the further slide. Assist control SIPP has variable rates decided by the baby, but the TI is fixed. In PSV mode, pressure support ventilation mode, even the rate is variable, and even TI also is variable. Intermittent mandatory ventilation, SIMV and SIPPV modes are time cycled, by default time cycled, whereas PSV mode is flow cycled. This is the basic of modes of ventilation, how they cycle. So coming to the basic mode of ventilation, the intermittent mandatory ventilation, where baby breathes on its own and the machine delivers fixed number of breaths at fixed intervals, irrespective of whether the baby is breathing or not. And it doesn't try to synchronize baby's breath with the machine's breath. So there is no synchronization. So here the control of breathing is pressure limited. Initiation is by the machine. So it's not synchronized with the baby. Termination is again time cycled. fixed tide time and fixed flow. And just take a second. Yeah. And support is controlled. So everything, control, initiation, termination, everything is controlled, and it is not synchronized with the baby. So basic problem with IMV, let's see. So suppose this all are spontaneous breath by the baby. These are triggered initiation of breaths by the baby, and these all are ventilator breaths. As we can see, baby is breathing on its own at some fixed rates, and machine is breathing on its own. There is no synchrony between machine and baby. So if you see, baby has started breathing, machine is starting giving its initiation, inspiration, and there's a gap between inspiration of the baby and machine. That's called inspiratory asynchrony. There is no synchrony between babies and machines inspiratory cycle. At the same time, baby has started breathing out, but machine is actually giving inspiration. So there is expiratory asynchrony. So there are two types of asynchrony here. Inspiratory asynchrony, where baby is breathing and is midway between in its inspiration, and then machine is started giving inspiration. Baby has started expiration, but machine is giving its breath. So this is expiratory asynchrony. So the basic problem with intermittent mandatory ventilation is asynchrony, both inspiratory and expiratory. So why are we worried about asynchrony? Asynchrony will cause more of increased work of breathing because machine and baby are not synchronized. Baby is breathing against the machine's breaths, so there will be asynchrony. Where there is increased work of breathing, there's chances of more air leaks because there will be fluctuations in even intracranial pressure. Also, there is a high risk of IVH. There will be increased duration of ventilation, and because baby is having increased work of breathing, clinicians try to give more sedation and muscle paralysis. So there will be increased side effects of sedation, muscle paralysis, due to which there will be prolonged ventilation, more of edema, decreased feeding. So overall, baby will be stuck in the ventilator, and there will be complications because of asynchrony. So to overcome all this, science has evolved, and they have tried to synchronize baby's breath with machine's breath. And this is what something called patient-triggered ventilation, where patient will trigger the ventilation and machine will try to synchronize each and every breath. So how does that machine synchronize? There are various trigger mechanisms. I've given a list of all this. The basic is flow trigger, which is commonly used in neonates. The others are pressure trigger, which is not commonly used. I've avoided nowadays. Other less commonly used are abdominal movement signals, thoracic impedance, esophageal pressure, and something called diaphragmatic signal in NAVA, which we'll be discussing later in the slide. Out of all this, I've given few advantages, disadvantages. The most commonly used is the airflow trigger, out of which there are two variable different modes of airway flow triggers. The heated wire anemometer is slightly better than the differential variable orifice, but whatever machine you have, you should know what is the trigger mechanism used. And if flow is there, it has advantages over pressure trigger. Because I'm assuming this has already been covered in the basics of ventilation, I'll not go into all this. But remember, flow trigger is better, flow sensor is better than pressure sensor as a trigger mechanism. So moving on to the various pressure patient triggered ventilation modes. The three basic modes are SIMV, assist controlled, and PSV mode. We'll deal with each mode one at a time. So moving on to SIMV mode. SIMV supports only fixed number of breaths. So what is the difference between SIMV and IMV? IMV is an intermittent mandatory ventilation where the machine is delivering fixed number of breaths to the baby, irrespective of whether the baby is breathing, when the baby is breathing. As the name suggests, synchronized IMVs, machine will deliver fixed number of breaths which the clinician will set, but those breaths will be synchronized with the machine. So there is something called trigger window, where machine will be waiting for that window to identify whether baby has started breathing or not. If baby has triggered that breath, it will initiate the breath and then machine will take over and give the fixed number of breaths. So every time it will do the same mechanism, it will wait for a trigger window. Suppose within the trigger window, the baby doesn't breathe, then machine will deliver at the end of the trigger window, it give a breath. So suppose you set a rate of 30 for the baby and baby is breathing at 40, it will try to synchronize at least 30 breaths with the baby, and rest all 10 extra breaths will be unsupported. Suppose you have set a rate of 30 and baby is breathing at 20, it will synchronize 20 breaths with the baby and rest 10 breaths which machine has to give, it will give its own breath. So machine will deliver 30 breaths irrespective of whether baby is breathing or not, and rest extra breaths with the baby is taking, it will be unsupported breaths. So suppose example, if baby's spontaneous rate is less than set rate, suppose baby's spontaneous rate is 20 and the set rate is 30, all breaths will be supported and ventilator will give extra breaths, suppose 10 breaths to achieve the set rate. If baby's rate is more than the set rate, suppose baby is breathing at 40 and baby's machine's breath is 30, 10 breaths will not be supported, 30 breaths will be synchronized with the baby. So it is a one step better than IMV, where the fixed number of breaths will be supported. So let's see. So control of breathing in SIMV is pressure controlled. Initiation of breathing is through the baby and it will be synchronized with the baby. That's a better advantageous point than IMV. Termination of breathing by default, this is a time cycle ventilation, TCPL, with fixed flow and fixed I time. And support is controlled. So almost similar to IMV, but the breaths will be synchronized. So this is SIMV. So let's see this pic again. So this all are spontaneous breath by the baby. So this breath, the trigger is identified by the machine. The moment baby breathes, machine gives this ventilator breath. And so this is supported breath. Baby's breath is using supported by the machine. So this is synchronized with the machine. This breath is unsupported because machine is already giving a breath, and in exhalation mode, this breath by the baby is not detected by the machine and is not supported. So this is supported breath. Again, this is supported breath. This is supported breath. These two are unsupported breaths. The machine is delivering at fixed states. So this is supported, this is unsupported. Let's see how it's better than IMV in terms of synchrony. Because the baby is already in inspiration mode and baby machine is not detecting that breath. This is inspiratory asynchrony. Baby is inspiring, but machine is not detecting that. That's inspiratory asynchrony. Baby is in exhalation mode, machine is still giving inspiration. So expiratory asynchrony. So better than IMV because some breaths are synchronized, not all breaths. So inspiration is synchronized somewhat, but expiration is not synchronized. This is a disadvantage of SIMV. Moving on to the next mode, science has evolved and there's something better mode of ventilation than SIMV. So there is something called assist control ventilation. So why is it called assist control? Where suppose you set a rate of 30, suppose you set a rate of 30, backup rate of 30, and baby is breathing at the rate of 45. Baby, I'll just take a break. I have to attend a call. Yeah, sorry. So assist control ventilation, where patients rate of ventilation is set by the machine, suppose it's at a rate of 30 as a backup rate, and baby is breathing at 50. So all the 50 breaths will be assisted by the machine. Suppose baby is breathing at less rate or baby is apneic, ventilator will go into a controlled mode where it will deliver its set backup rate. So there are two modes here, assisted and controlled. If the baby's breathing is equal to or higher than the set machine rate, it will assist all the breaths. Controlled mode, when the baby's breathing rate is less than the ventilator's backup rate, where it will control all the breaths. It will be delivering the set fixed rates of 30 breaths. Thank you. Yeah. So sorry, actually, there's a call from the hospital. I have to take the call. So assist control ventilation, where baby will be assisted by the machine ventilator, and if baby is not breathing, it will take a complete control of the machine. It is almost similar to SIMV, but in SIMV, extra breaths are not supported, but in assist control ventilation,
So your voice is not there. Hello. Uh, Dr. Gopal, sir.
So am I audible now?
Yes, sir,
Yes.
you're audible now.
Just a minute. So I
Ventilation then. Okay. So in assist control ventilation, the patient here is difference of SIMV and assist control is all the breaths which the baby triggers are assisted by the machine. Suppose we set a rate of 30 and baby is breathing at the rate of 50. All the 50 breaths will be assisted by the machine. Suppose we set a backup rate of 30 and baby is breathing at the rate of 10 or 20, baby will still deliver 30 breaths. So it is a control mode where baby's rate is less, but machine will deliver a set backup rate. That is called control mode ventilation. Assisted mode where baby will deliver all the breaths if the rate is more than what we set. So this is assist control. And assist control ventilation is different names in different machines. So some machines have SIPPV, synchronized intermittent positive pressure ventilation, and some machines have goes by the name of patient triggered ventilation also. So assist control, PTV, and SIPPV are same, exactly same. Different machines have different names. So let's see this assist control. The control of breathing is to pressure mode. Pressure, this is a TCPL. Time cycle, termination of breathing is in time cycle. Initiation of breathing is synchronized with the machine. So this is a spontaneous breath, and this is the machine's breath. All the breaths initiated by the baby will be supported by the machine and synchronized with the machine. Support, if the baby is breathing well, all the breaths will be supported. Unlike SIMV where only some breaths will be supported. If the baby is not breathing, it will go into a control mode. Let's see this graph where these are spontaneous breaths. All the breaths which are triggered by the baby are delivered and supported by the machine. So all the breaths will be supported. So this all are supported. All the supported breaths are assisted by the machine. Inspiratory synchrony is complete in assist control mode, where once the baby triggers the inspiration, machine will have inspiratory synchrony. So complete inspiratory synchrony is there. But when here the baby is actually exhaling, but still baby is delivering inspiration. So there will be some degree of expiratory asynchrony in assist control. So a complete inspiratory synchrony, but expiration is asynchronized in all the breaths. Let's look at the advantages of assist control or SIPP mode over SIMV. Assist control mode, all the breaths are supported. In SIMV, only fixed rates are supported, rest all breaths are unsupported. Because of inspiratory synchrony, complete inspiratory synchrony, there will be minimal work of breathing compared to SIMV. In assist control, all the breaths are supported, so there will be better tidal volume to dead space ratio. In SIMV, the unsupported breaths will have lesser tidal volume to dead space ratio. We'll not go into detail of all this, but assist control is a better mode of ventilation than SIMV. Let's focus on this flow time volume curve. Here in an IMV, there is complete asynchrony and this heterogeneous breath being delivered across all the breaths. If you talk of IMV, supported breaths and unsupported breaths, there's better homogeneity with respect to breaths compared to IMV, but there are supported and unsupported breaths are heterogeneous. We can see gross difference between both of them. But compared to SIMV, PTV mode or assist control mode have complete homogeneous breaths as all the breaths are supported equally. So, but just seeing this picture, you can see that assist control mode is a better ventilation mode compared to SIMV. So what is the issue with SIMV and assist control? Suppose we feel that assist control is better. Let's see. So this is a pressure time scalar waveform where this is inspiration, this is expiration. If you see the flow time curve, this inspiration, there will be a duration of inspiration I time where there will be effective ventilation will not be there. And the breath will be held in peak inflation for some time, due to which this is actually ineffective. And then there will be cycling. So there is a fixed I time and there is something called inspiratory hold, where this duration of breathing actually doesn't help the baby, and there'll be increased work of breathing because of inspiratory hold. To overcome this, there's something called PSV mode, pressure support ventilation mode, where there'll be inspiratory pressure boost to all spontaneous breaths, and by default PSV is flow cycled, so this enhances synchrony, and it can be used with SIMV also, but you can use PSV also as a standalone mode of ventilation. And there's something called, to ensure flow cycling, there's something called termination sensitivity. Let's see what is termination sensitivity. So suppose the peak flow rate is 10 liters per minute. So we set the termination sensitivity. Suppose I set the termination sensitivity at 15%. Once the flow is declining and it reaches 15% of peak flow, suppose peak flow is 10 liters, once it reaches 1.5 liters, it will go into exhalation mode. It will not go into complete zero flow. So it's a better advantage because there is no inspiratory hold, and we can set the termination sensitivity as per our wish. It can be between 5% to 25%, some allow even 40 to 50% also. So good termination sensitivity is between 15 to 25%. So percentage of peak flow when it reaches, machine goes into, cycles into exhalation. So there'll be no inspiratory hold. So PSV, again, pressure controlled mode of ventilation, synchronized with the baby, by default flow cycle. So time is variable and all the breaths are supported. So here the inspiratory synchrony is there because all the breaths are triggered by the machine, by the baby, and synchronized by the machine. Termination is dependent on the baby, and because this is flow cycled, even expiratory synchrony is there. So only problem with PSV is because there might be some breaths where there'll be very small eye time, the map might not be achieved. So when you use PSV mode, by default, you have to increase the PWP to maintain the map. That is the key point when you use PSV mode of ventilation. You have to increase PWP. So till this point, we have discussed SIMV, assist controlled, and PSV mode of ventilation. So if we feel that these all modes are very good mode ventilation, so why are new modes present, or why are hybrid modes we are talking of? Let's go into something called ventilator-induced lung injury. So there are 5 basic trauma which machine can give. 2 most common are barotrauma and volutrauma. Other are rheotrauma, atelectotrauma, and biotrauma. So we'll focus more on volu and barotrauma. So by default, over decades, people had something called barophobia. They didn't want to give pressure, but over time, it has been seen that volutrauma is more dangerous. So barophobia is there, but it's controversial. Voluphobia should be there. So, and the only advantage of pressure controlled ventilation is you can ventilate despite large leaks. The rest all volume controlled ventilation is better than pressure controlled ventilation. We'll see over next 10 minutes. Pressure controlled ventilation is you give fixed pressure limit, and the tidal volume delivered is dependent on the compliance of the lungs. If the lungs are stiff, the tidal volume will be low. If there is a highly compliant lung, the tidal volume will be high. So because the compliance is so variable, there is chances of over distension and there is chances of air leak and injuring the lung. So pressure controlled ventilation is by default less advantageous than volume controlled ventilation. Let's see this compliance curve where volume is fixed, pressure is fixed, but depends on compliance of the lung. If the compliance is very low, the volume delivered will be low. If the compliance is high, the volume delivered will be high. So pressure is fixed, but the volume is variable. At the same time, let's see what are the advantages and what are the principles of volume controlled ventilation. The tidal volume is set here, and pressure is adjusted to deliver the set tidal volume. Here, the volume is fixed, pressure is adjusted. The lower the compliance of the lung, or the lung is stiff, higher pressure is needed to generate the tidal volume. And the major advantage of volume control ventilation is you have auto-weaning. So if the compliance is better, automatically pressure will be weaned off and there'll be auto-weaning and you can extubate early. Here, if you see the same compliance curve, the volume is fixed here. And depending on compliance of the lungs, if the compliance is very good, you might need less pressure. If the compliance is poor, you will need higher pressure. So volume is fixed, tidal, and the pressure is variable. So which is better, pressure and volume? Let's see. So various animal studies have shown that if you give a fixed pressure and the tidal volume is variable, and you compare another animal where the tidal volume is fixed, it has been shown that the animal who has received various tidal volume and this variable tidal volume, the injury is more prone to damage compared to a fixed tidal volume. This animal studies have proven this. And there are more episodes of hypo and hypercarbia in pressure controlled ventilation compared to tidal volume ventilation. So you have animal studies which have shown advantage of volume control. Even in human studies, the degree of hypo and hypercarbia is better in volume control compared to pressure controlled ventilation. And we have a real-time weaning of pressure and shorter duration of ventilation. We have evidence for this also. We'll see later. So just I'll take few seconds of this basic of volume ventilation, where ventilator delivers a fixed volume through sensor into the circuit, and the volume delivered from this point to this point is dependent on the compliance of the circuit, the volume which is lost in the circuit in the humidifier, and the AT tube leak. So water is delivered at here, this point should reach at this point, but this is not the case because there are variables which cannot be controlled, and there are various leaks, and the ultimate volume which reaches the baby is the key. So drawbacks of volume controlled ventilation is the tidal volume is measured at the ventilator end of the circuit, and there are huge ET tube leaks. So if the leak is high, volume ventilation cannot be done. I'm talking of volume controlled ventilation. There's something called volume guarantee, which we'll discuss later on. Volume controlled ventilation, tidal volume is measured at the ventilator end of the circuit, not at the patient end. But nowadays there are machines which measures the axial tidal volume. That is a better sensor, better module of measuring the tidal volume. So to bypass all this and overcome all this, volume guarantee ventilation has come up. Various machines have different names, but by default it's a volume guarantee, where it is a time controlled pressure limited ventilation and volume targeted. We'll see how it works. It can be combined with SIMV, assist control, and PSV. That's why it's a hybrid mode. The basic mode is TCPL, but it's volume targeted. And auto feedback guarantees tidal volume. The previous breath tidal volume adjusts the next few breaths. And by default, axial tidal volume is used to calculate the volume guarantee, which is being delivered in the next breath. Let's see this pic. So suppose with a set pressure, the set tidal volume is delivered. This will be detected by the machine, and it will deliver the next breath with the same pressure. And we'll see with the same pressure what is the tidal volume is being delivered. If the set tidal volume and the actual tidal volume is less than the set tidal volume, next breath it will increase the pressure, and it will again check the tidal volume delivered. If it reaches the set tidal volume, next breath it will give the same pressure as the previous breath. Suppose in this breath the tidal volume is high, in the very next breath it will decrease the pressure. So it will keep on changing the pressure limit, pressure being delivered depending on the previous tidal volume. That's the key. So it's an automated regulated pressure delivery depending on previous tidal volume and pressure. There is something called working pressure. Around that point, the machine will be working around. The safety limit is whatever set tidal volume you set. Suppose you would set a tidal volume of 10, 130% of target. So it will not deliver more than 13 ml. So there is a safety net for this machine, that it will not deliver more than 130% of target. It will not overshoot beyond that to prevent air leaks or pneumothorax. So how do we decide what's the right volume? So one size doesn't fit all, remember. So it depends on what baby you are dealing with. So it depends on infant size, the disease condition, and the duration of disease. Smaller the size, greater the tidal volume per kg. Why? Because there is a fixed anatomical dead space. So the flow sensor which is being used has 0.6 to 1.2 ml of dead space. Irrespective of weight of the baby, that dead space is fixed. So if the baby is smaller, the proportional tidal dead space is high. So smaller the baby, we need to use higher tidal volume. The disease condition, suppose BPD, MAS, have more dead space. So you need to overcome all the dead space and increase the tidal volume. So depends on the disease condition. So I'll just give a table of what is a rough idea of the tidal volume you should set. For a normal baby, it's 4 to 4.5 ml per kg. And RDS, the tidal volume will keep on increasing as the size decreases. So smaller the baby, higher the tidal volume. In BPD, the tidal volume will be higher to compensate for the dead space. Similarly, in MAS also, the dead space is there, so you need to increase the tidal volume. CDH is almost like a gentle ventilation as for a normal baby. In established BPD, you need to go very high tidal volume to compensate for the dead space. So this is the rough idea of tidal volume which should be used. So what is the advantage? Till this point, we have learned about volume guarantee, volume ventilation, and pressure mode ventilation. There's enough advantage to show that there is a meta-analysis or around 1,000 babies, which shows that the rate of death or BPD at 36 weeks, air leaks, duration of ventilation, hypocarbia, and severe IVH are markedly reduced, significantly reduced with volume ventilation compared to pressure ventilation. So by default, we should be using volume ventilation wherever possible. And if you're not comfortable with ventilation, we should be switching to pressure mode ventilation. Next few minutes, I'll just give a guide of how to decide and how to use volume ventilation. So as early as possible, once you start ventilation, you should start volume guarantee or volume ventilation. Assist control or PSV is preferred to SIMV when you are using volume guarantee, because you need in assist control, all the breaths will have volume guarantee. In SIMV, only the supported breaths will have volume guarantee. So assist control is preferred with volume guarantee. As I've already talked, in volume guarantee and PSV modes, you need to increase the PWP, open the lung, so that there'll be enough ventilation. And because ventilation is very, very closely related to flow sensor, ensure that flow sensor is functioning and is well calibrated. Otherwise, your whole volume ventilation will be erroneous. Target what to set, we already discussed. And PIP limit 3 centimeter or to 5 centimeter above expected PIP requirement. Suppose you are expecting a PIP requirement of 18, set a PIP limit of 21 or 22. So when you start off with ventilation in volume guarantee, you set a PWP as per baby's condition, ensure that flow sensor is working, choose assist control mode of ventilation and volume guarantee, set a tidal volume, and set a PIP limit. You cannot set PIP here. PIP will be variable, but you'll need to set a limit which should be at least 5 centimeter above expected PIP requirement. Once you start off with ventilation, you should adjust your tidal volume 0.5 ml per kg each time, predominantly depend on the pH of the baby, not on CO2. And if you feel the baby is having tachypnea or retractions on volume ventilation, you should try to increase the tidal volume. And whenever you feel that baby is comfortable, you should try winning the PWP, and tidal volume should be the last to be weaned off. Whenever the required PIP is below 15, we should try to extubate. In particular, in preterms, extubate to some support of NIPPV, CPAP, or high flow. So there are few other hybrid modes of ventilation. So there are some various machines, ventilators which use this modes, PRVC, VAPS, and PV. I'll just take one slide of each just to complete the module. So PRVC is the name of ventilation particularly used in servo I. This is similar to volume guarantee, but this is a pressure control and flow cycle. The only difference is it delivers breaths in the next every 3 to 4 breaths. It will keep on adjusting its breaths, not as volume guarantee. Volume guarantee is purely dependent on the previous breath, one breath. Here, it's an average of previous 4 breaths, and it will be an escalating and de-escalating control or variation. I'll just see through the this thing graph. So the pressure will slowly keep on increasing 20, 22, 24, 27 to get the tidal volume. It will not jump to in the next breath. So it will be a slowly escalating and de-escalating. The other disadvantage of servo I is in PRVC mode, the tidal volume is detected at the proximal end, at the ventilator end, which is not good. The tidal volume should be measured at the patient end because the leak is properly detected in that. Something called VAPS and PAV. I'll not go into detail of that. So there's something called newer mode called NAVA. So there is an entity called electrical activity of the diaphragm. The trigger, there's a nasogastric catheter at the level of the diaphragm through the esophagus, and that measures the activity of the diaphragm. Depending on the intensity of that activity, the pressure or volume of the breath delivered is proportionate to the trigger. So this is almost synchronized with the baby. Once the baby has some activity at the diaphragm, that trigger actually identifies and breath is delivered completely in synchrony. So NAVA is the complete synchronized mode of ventilation. The only disadvantage is it's not easily available, it's very costly, and it's not completely evidence-based. Evidence is coming up, probably next 5 years, we'll be having more evidence on NAVA. So in next 5 minutes, we'll be discussing how to ventilate. So every disease has a different etiology, pathophysiology. We should understand the pathophysiology when we are ventilating the baby. So develop a specific strategy for a specific disease. We'll see how we'll do that. And you should choose a ventilator which you know how to deliver that specific strategy. And the moment the disease changes also, you should change the ventilator strategy and always work towards an early extubation. The moment you intubate, you should decide when to extubate to minimize ventilator-induced lung injury. So you should be very clear about the disease and the ventilator which you are using. So let's see if the common 3 to 4 common diseases. So basic pathophysiology of RDS is it's a diffuse alveolar disease with more atelectasis and predominantly because of surfactant deficiency, and sometimes it's triggered by inflammation also. So diffuse disease with homogeneous atelectasis. So here the compliance is very low. Once the compliance is low, time constant, which already discussed in the previous talk, I feel time constant is so inspiration time is predominantly 3 times of time constant, and time constant is compliance into resistance. The moment compliance is low, time constant will be low. So by default, I time will be low. So any baby whom you feel has RDS, the I time should be set to be towards 0.3 to 0.4 seconds. And rough rule of thumb is usually initial I time is as per gestation. Suppose a 28 weeker, you have an I time of 0.28. 32 weeker, you have an I time of 0.32. So lower the gestation, lower the I time. Because this is a homogeneous disease, with atelectasis, the PWP should be adequate. It should be anywhere between 5 to 8, and gradually keep on increasing PWP every 15 minutes if not able to ventilate. And tidal volume should be higher. Smaller the baby, higher the tidal volume, which already discussed. So less I time, adequate PWP, and adequate tidal volume should be the key of ventilation in RDS. With respect to rates, suppose you are giving a assist controlled ventilation and you are expecting a baby to be breathing at 50, set a rate of 10 lower than expected breathing rate. So baby is breathing at 50, set a rate of 40. So baby is breathing at 60, set a rate of 50. So 10 less than what the baby is breathing at. So low compliance, low tidal time constant, low I time, because this has diffuse atelectasis, increase PWP, and keep on increasing till the point you reach 8 and 9 of PAW. Coming to MAS, it's not very simple as RDS. So MAS has obstructive features where there'll be some air and there'll be some complete obstruction leading to collapse. There'll be inflammation leading to surfactant dysfunction and protein leak. There'll be pulmonary vasoconstriction leading to BPHN. So there are three components here. There'll be air trapping, there'll be surfactant dysfunction, there might be BPHN also. So because of this variable pathophysiology, MAS is a difficult disease to deal with. Just let's discuss about the ball valve effect. In MAS, during inspiration, the meconium doesn't obstruct the airways completely, so air is able to go inside, but during exhalation, the airway collapses, so air is trapped inside, leading to more air leaks. So this is ball valve effect, typically seen in meconium aspiration. So inspiration, air goes in, but is not able to come out. So air is trapped in. So looking at X-ray picture, you can decide whether you're dealing with an obstructive pathophysiology or an alveolar disease. Suppose you have a low volume lung with whiteout picture in MAS, you're probably dealing with a low compliant lung with surfactant dysfunction. So give high PEEP and treat as per RDS and give early surfactant. Suppose you have heterogeneous picture with some degree of collapse and some degree of air trapping with hyperinflation, probably you're dealing with ball valve effect or increased resistance. Here, you need to give low rates, low I time and sufficient E time, expiration time, so that air goes out. You need to give sufficient PEEP so that the airway doesn't collapse. Because MAS with gas trapping has dead space, you need to increase the tidal volume. So here, low I time, low rates, moderate PEEP with slightly increased tidal volume to compensate for the dead space. So other condition is lung hypoplasia. Common conditions are CDH, oligohydramnios, and omphalocele. So here it's almost like a normal lung ventilation. It's more like a gentle ventilation. So normal lung tidal volume of 4 to 5 ml per kg, mild to moderate PEEP with avoidance of overinflation. So it should not injure the normal lung. So in CDH, one lung is hypoplastic, but other lung is completely normal. We need to ensure that we're not harming the other lung. So gentle approach with acceptable CO2 is the norm in lung hypoplasia, particularly in CDH. So the last is BPD, where this is again complex disease, where the complete airway from the glottis to the distal airspace is affected. Predominantly there is stenosis, there is tracheomalacia and bronchomalacia. Bronchioles have smooth muscle hypertrophy with increased secretions, and the alveolar spaces have actually, the septum is thickened, and there is hypoxemia with some degree of dead space also. So from complete glottis to the airspace is involved. So we need to deal with all this mechanism area ventilating a BPD baby. So early on, when there is mild to moderate BPD, you need to increase the tidal volume to compensate for the dead space, slightly increased PEEP because of tracheo and bronchomalacia, increase I time to deliver the breath with slightly lower rates. In severe or chronic BPD, again, you need to increase the dead space from 5 to 8 to 6. We can go up to 12 ml per kg to compensate for alveolar and anatomical dead space. To stent the airways, very high PEEP and less rates of around 15 to 20 breaths per minute with sufficient I time and E time to allow air to come out. So high PEEP, high tidal volume, low rates, sufficient I time and E time. This is the key of BPD ventilation. So just summarizing what I have discussed over the last 45 minutes to 50 minutes, always use PTV if available, and ensure that because synchronized ventilation is dependent on sensors, ensure the sensors are functioning and prefer flow sensor over pressure sensor. This has advantages. Flow sensor is better than pressure sensor. If at all you are using assist control and SIMV, always prefer SIMV, assist control or SIPPV over SIMV in acute ventilation. PSV should not be used in the acute ventilation stage, particularly for first 2-3 days when babies have very high rates. Suppose baby is breathing at 60 to 70 breaths, the I time is very less. So adequate MAP is not been delivered. So in acute stage, avoid PSV. PSV should be used once the ventilation settles down and during weaning phase. Use any mode which you are comfortable, either SIMV, SIPPV or PSV. but use that mode consistently and be comfortable with whatever mode you're using. Always start volume ventilation wherever possible, as early as possible. It's better than TCPL with less incidence of air leaks, IVH, and BPD. Whatever ventilator you're using, be comfortable. And as per the disease, apply your common sense and remember what is the tidal volume to be delivered, what is the I time to be used, what is the rate to be used. So there are only few variables we need to change. As per the disease, you need to change your ventilator settings. Thank you. I would be happy taking questions.
Yeah, thank you so much, sir. Now we are open for questions. If anyone have any question, please put in chat box. Any question, please put in the chat box. There is a question, sir. What is
Yeah.
flow starvation in PSV mode of ventilation? By Dr. Rajiv.
What is flow starvation?
Yeah.
Yeah, so suppose you're giving a breath and so suppose baby has triggered a breath and because it is dependent on flow, you're giving a flow and the machine delivers a breath and the flow rate is quite less. Suppose you can set flow for the machine. Suppose you're delivering a flow rate of 5 and baby's machine is not able to deliver the pressure which is or tidal volume which is desired, there will be flow starvation and baby will try to actually take a breath in between as the baby machine is delivered. So there'll be flip of flow as the machine is delivering. So because the flow rate is set less, machine will try to deliver the breath, but baby will try to take a breath. So that's called flow starvation. So that adequate ventilation pressure and volume will not be delivered in PSV if the set rate of is flow is less as desired. So adequate tidal flow rate for a machine should be around 8 to 10 liters. So some machines you can change the flow. If there is no variable which you can set, by default, most of the ventilators have a flow rate of 8 liters per minute.
Any other questions?
I think just to summarize, assist control mode or SIPP mode is preferred whenever you're using ventilation. And if you're comfortable with volume guarantee, use volume guarantee along with SIPPV. But always ensure that when you're using volume guarantee, adequate PEEP is being delivered because PIP is variable. So adequate PEEP is used. And there'll be auto-weaning. So don't wean off the rates and avoid changing the volume frequently. Just ensure that you set a proper PIP and PWP. So usually volume guarantee is very easy and once you know the machine and the technique, it's very easy to use.
There is another question. What's the difference between volume targeted and volume guarantee mode?
These are by default different names. So Honda has a different name, Hyundai has a different name of the same car. So volume targeted and volume guarantee. Volume guarantee is predominantly given to by as far as I remember, it's more of Draeger has used volume guarantee. SLE uses the name of targeted tidal volume, so TTV. So different names given to the same technique. There's no difference between volume targeted and volume guarantee. Volume controlled ventilation is different to all of this. Volume targeted and volume guarantee is different from volume controlled ventilation. Volume controlled ventilation is by default a volume ventilation, not a pressure ventilation. So you set a tidal set volume and machine will deliver its own breath with a I time, fixed I time. and there it's not titrated as per previous breath. It's not variable. So as we give a fixed pressure, volume also is fixed. So it's not currently used nowadays. So by default, is volume targeted or volume guarantee. So maximum PIP, there's nothing called maximum PIP. You need to see a working pressure. Suppose you have used SIPP mode without volume guarantee and you see that usual pressure is 18. So you set a PIP limit of 23, 5 centimeter above the working pressure. So if you set a very low PIP limit, you'll have more alarms. So you need to give 3 to 5 centimeter of PIP limit above the working pressure. In volume guarantee, there's nothing called maximum PIP.
The next question is, how is permissible hypercapnia maintained in CDH or MAS with PPHN? As acidosis can lead to increase in pulmonary vasoconstriction.
So there are evidence to it, although evidence is also contradictory. But acceptable CO2 is between 55 to 60 if the pH is more than 7.25. People also accept 7.2. So if pH is less than 7.2, people don't accept very high CO2. So you have to balance hypercarbia along with acidosis. So permissible hypercapnia of 55 to 60 is acceptable if the pH is more than 7.2. That's the key.
There is another question by Dr. Rajiv. For hypercarbia, which one to regulate, rate or increase tidal volume?
So if you're using SIMV mode, suppose I'm talking of different modes, SIMV modes, you need to increase the rates. If you increase using assist controlled ventilation, changing the rate doesn't matter because already baby is breathing fast and all the breaths are supported. There you need to increase the PIP or PWP if you're using assist controlled ventilation. In volume guarantee ventilation, rate usually doesn't matter. You need to change the tidal volume if there is hypercarbia. If there is baby is breathing very fast and you feel baby has walker breathing with hypercarbia, probably you are giving less tidal volume. Increase the tidal volume, that will help the baby. And also at the same time, ensure that the airway is not obstructed. ET is clear. Usually rate is not changed, frequently in volume guarantee and assist control ventilation because it acts as a backup rate. Weaning is automated in volume guarantee. So you set a tidal volume of suppose 5 ml per kg, you set a PWP and PIP limit. So once the baby's compliance is better, the working pressure will improve from 20 to 15 to 12. Once you see that for certain duration, working pressure is between 12 to 15 and baby is comfortable, breathing well, and there is good effort is there and FI2 requirement is less than 30%, probably the baby is ready to extubate. Some people wean off the tidal volume to 4 ml per kg then extubate, but anywhere between 4 to 5 ml per kg is good enough to extubate.
This is the last question, sir. There are no any other questions or queries.
Yeah.
Thank you so much, sir. It was like from all the modes and basics of ventilation to clinical application is being well covered in 1 hour. So that was a very useful, informative session for today. Thank you so much. I think there is no any other doubt, so we can close the session for today.
If you have a group or something, I'll share the PPT. Probably that will be more advantageous because covering all the aspects of ventilation from volume guarantee, from modes to DG specific is slightly lengthy. So I had to rush few slides, but I'll share the slides and probably that will be useful for the fellows.
Okay, sir. Okay. Thank you so much.
Thank you.
Thank you, sir.